So this week's Sangria Sisters blog is about skin cancer, and I can't think of anyone better to discuss this subject with than my friend, my boss, and a dermatologist extraordinaire, Dr. Ken Alanen.
Thank you.
Welcome to the blog.
It's great to be here, Lori.
Thanks.
And Valerie from across the room.
Hello! Yeah.
Okay.
First things first, we would like to discuss your credentials, just to make sure that we didn't pick you up off 17th Avenue, washing windshields, or anything like that. Or
For
a
sure.
park bench, whatever.
I'm a pathologist. Yes, we're on TV and you see autopsies and all that exotic stuff that they do, but most pathology is diagnosing cancer under the microscope. So after my pathology training, I became a skin-specific, what's called dermatologist, and I've seen 250,000 odd skin specimens under the microscope. And after that show that I was sort of a glutton for scholastic punishment, I became a dermatologist, and then after that did skin cancer surgery training. So skin cancer is basically my life.
How many years would that have entailed?
17 years of school.
And board certified in Canada and the United States.
Both sides, correct. Mm-hmm.
17
Yeah.
years. Just want to let that one sink in for a second.
Yeah. Sort of a teenager kind of thing, right? Yeah.
Right. So did you want to talk, first of all, what the visual effects of skin cancer?
The visual effects being
on aging. Let's discuss. We have so many friends out there that just love that golden brown tan.
Yes.
They want to. I have never been able to achieve it because I'm Scottish, so I get the polka dot look. But outside of the golden brown tan, what is it that you're actually doing to the skin when you're out in the sun or getting the Fabutan vibe?
Suntan pigment is the body's response to ultraviolet light, and so you can't get a suntan without UV exposure, and that is relevant because ultraviolet light is classified as a type 1 carcinogen, and the link up between ultraviolet exposure and skin cancer is stronger than the link between smoking and lung cancer, so it is definitely a health hazard.
What about aging? What does it do to your skin?
So
accelerate it, obviously.
That's what we really want to know.
Sure, that's what everyone seems to want to know. Yes, and so it causes thinning of the skin. It causes overgrowth of capillaries. It causes very splotchy pigmentation, large pores, overgrown oil glands. Essentially, everything that we do cosmetically relates to a lifetime of sun exposure. Everything except for Botox for muscle-induced wrinkles. Yes.
And how do you get skin cancer then?
Skin cancer, there's three major kinds of skin cancer. There's basal cell carcinoma, squamous cell carcinoma, and melanoma. They tend to be, basal and squamous in particular, have a very strong association with sun exposure, ultraviolet exposure, and that's why most of them are on the face. And that can be devastating, particularly if you get a skin cancer at a young age, because the therapy is almost always surgical, and so we go to great lengths when we remove skin cancers surgically to make sure that the cancer is gone and that the scar looks as beautiful as possible. Yeah.
So you remove basal, you remove the squamous,
and melanoma.
And melanoma. And so actinic keratosis then is a precancerous?
Yes, we call it a potential precancer. If you call it a precancer, it implies that sense of inevitability, but many of them do. And so I want to see patients when they have actinic keratoses, and because the therapy for that is more straightforward than it is as compared to removing something surgically.
Right.
Okay.
So, but something like a basal cell, it's the actual. What's the worst? That's the
melanoma is the worst one.
Yes, right.
But in terms of risk factors, the risk factors are the same. Age, sun exposure, a history of sunburns as a child, positive family histories. And so if you're at risk of basal cancer, you're also at risk of squamous and melanoma. So we're always doing mole patrol, mole surveillance for all three kinds of skin cancers.
So it is hereditary?
There's a hereditary risk.
Oh,
yes,
I
there
didn't
is.
actually know that.
Yeah. Mm-hmm.
And so to prevent, something that you could do at home is to do a head-to-toe mole check. You should be checking your skin constantly. And what are you looking for?
Spots which change. There's this expression in dermatology that every melanoma cancer looks different than every other melanoma cancer, but what they all have in common is the tendency to change over time. So if you have a dark mole and it doubles in size, that's the sort of thing that a dermatologist needs to know about. Basal cell carcinoma looks as though like it's a pimple that never goes away. And if you have a non-healing pimple, and a common story is that you're doing your morning towel down, you're doing your morning routine, and the pimple is always there. Remember, pimples, they should go away after several days to maximum several weeks. And so if you have a quote unquote pimple that's not going away, then it should be seen by an expert.
And for me, it was a little bit of bleeding every now and then.
Exactly.
Very rare, but
yes, if you have a spot that bleeds.
Yeah. Bleeding spots on sun damage can get an awful lot of respect here.
Yeah.
They do.
Yeah.
So let's say you haven't caught it in time and it is melanoma. What would be the next step?
Melanomas are removed surgically, and it's a matter of freezing up the skin, excising it in its entirety, and it's sent out to the laboratory for definitive staging. Most melanomas are still diagnosed at the early stage, but melanoma is the bad one because if it's not detected on time, there's a genuine mortality rate that comes with it.
Does it go in your bloodstream, or what does it like?
Yes, melanoma basically invades into blood vessels, so it can spread to organs distant from where it started, whereas basal cell carcinoma and squamous cell carcinoma, they tend to be what are called locally destructive. They get bigger and bigger and bigger, and they can eat into adjacent anatomic structures, but they very, 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 and only very rarely spread.
And when you do Mohs surgery, you're taking it layer by layer then?
Yes. The benefit of Mohs surgery is that you remove as little tissue as possible, so everything that needs to go does go. And instead of sending the tissue out for testing, it is kept within the clinic. There's a laboratory within this clinic, and I examine the tissue in my capacity as a skin pathologist. If there's more cancer that remains, a bit more and a bit more and a bit more is taken, so that when the final surgical defect is achieved, it's cancer-free 98.7% of the time. So it's the best possible procedure because the cut is as small as possible, and there's an almost 100% degree of certainty that the cancer has been removed.
So rather than digging it out right off the bat with an ice cream scoop and going really low, you're going to do it minimal and it's invasive.
And that's what still happens in many, if not most, surgical centers in this country, is that if you are surgically tentative and you want to make a scar as small as possible, then there's a genuine risk of leaving cancer behind. Then it's back to square one. Conversely, if you're overly aggressive surgically and you know for sure you're going to get, then the cut is unnecessarily large. And so Mohs surgery is simply the Goldilocks zone. Not too big, not too small in terms of the excision. Okay.
And so ABCDs still apply?
Yeah, ABCDs, that relates to how to, it's a guideline, it's not a rule which is carved in stone as to how to evaluate a brown spot. So a mole which violates ABCD criteria is sometimes, although not always, concerning. So an A is an asymmetrical mole, B is border irregularity, C is color irregularity, D is diameter over 6 millimeters, and the most important one is E. E is elevation or evolution. Evolution as in how does the mole change over time. So when I see a mole at a fixed point in time, what I really want to know is what did it look like 6 months prior? Because even if the mole looks unusual, if it hasn't changed, if it hasn't grown, if it hasn't assumed a bizarre pigmentation pattern, then it can be left alone. But if the mole violates those criteria, we tend to remove them. We also do what's called mole mapping, and it's a very common thing in Australia. It's less common in North America, but it allows for the detection of subtle change over time. So high-risk patients with innumerable moles, they get this computer-assisted photography system, and the computer software is better at detecting subtle change than the patient or the physician.
So it's like mapping out the stars almost. It knows exactly where all the moles are.
Yes.
And then next time you go back in and do it again, it'll be able to tell if they've changed, if there's more, or if there's...
Exactly. If Orion's belt has assumed an extra star.
Exactly.
Well, you had mentioned to me that because I have everywhere, and I have very large spotted arms, but you told me that you're looking more for like smaller, darker dots. Is that...
Yeah, there's multiple different kinds of brown spots. So many things can violate ABCD without being remotely worrisome biologically. In simple terms, there's nevus, keratosis, and lenticle. Those are the 3 main categories of brown spot, and multiple subcategories within. Only nevus has a cancer risk. So if a keratosis violates all those criteria, it doesn't matter. So that's sometimes the difficulty, because I'll often see patients who are terrified, justified, because their spot is weird, and yet it's perfectly benign and not worrisome medically because it is not a nevus. Right. So that's my job to decide which flavor of brown spot it is and if it needs to go.
Well, you've even helped people in like grocery store lineups and things, haven't you? Said,
it's a
very suspect. If I were you, I'd be.
It's sometimes shocks people, but when you consider what is dermatology, it's external medicine. So the training to become an expert in skin disease is what does it look like clinically. And so I'll often say, if you've seen a Volkswagen Beetle, you know it's a Volkswagen Beetle because your mind has been trained over the years to recognize that car as a Volkswagen Beetle. That one's a Cooper Mini, that's a BMW. It's the same thing with dermatology. So if it's not a medical situation, if trained eyeballs are seeing skin, you can still make, and you do make diagnoses.
So, going forward, then, what would be the best way to protect yourself from getting any of these cancers?
Avoid sun exposure as much as possible. We're zinc oxide-based sunscreens. They block out almost all of the carcinogenic spectrum of ultraviolet light, both UVA and UVB wavelengths.
Can you still get a suntan?
If you get a suntan, you're not using enough.
Oh, okay.
Yes.
So basically, you don't want to even have a tan.
You don't want to tan. We're trying to change the mindset. Brown is bad, is what we're trying to say. A brown pigment and a brown tan basically means you're damaging your skin.
And UVB is the one that burns. That's the ultraviolet light that burns your skin. UVA is the one that causes the cancer.
Well, they both cause skin cancers.
Okay.
Ultraviolet B burns you. Ultraviolet B is only 5% of ultraviolet light. So 95% of ultraviolet light is UVA. So in days gone by, people would think that they were protected because they weren't burning. So if they had a sunscreen which only blocked out ultraviolet B, but not much of UVA, they would be in the sun with the illusion of protection. So they actually would be getting more damage to their skin cells because they weren't burning. So we now know that we have to be mindful of the fact you have to have a good SPF, somewhere hovering between 30 and 40, and that you need to be mindful of ingredients. And so we preach zinc oxide as the sunscreen agent of choice because it blocks out everything. It doesn't get absorbed in your body like crazy bad chemical sunscreens do. It's natural, and it stays on your skin essentially all day.
So say like Umbrella or those aren't as effective?
I tell people ignore the brand as much as possible.
Okay, just look for
take
the
note of the
ingredients,
SPF number, but the most important thing to do is to ignore the pretty label, flip it over, and see what's in it. Yeah. And the ingredients matter.
Because the higher SPF is not necessarily giving you better protection. It's just laden with more chemicals to get.
And once you get beyond an SPF 40, the SPF is essentially a marketing gimmick.
Okay, well that's a question because I just saw SPF 85.
I've seen SPF 110.
Oh, okay. I thought, well, that can't.
It's an absolute marketing gimmick, unfortunately. Okay. But people, understandably, we're all busy, and most people don't do what I do for a living, and they justifiably respond to marketing and say, oh, it's a bigger number, ergo it's a better product. And unfortunately, that's not the case.
So you should reapply it several times.
Particularly if you wear a chemical sunscreen, because chemical sunscreens, even if you're not sweating, even if you're not swimming, there's only so many rays of sunshine that they can absorb before they break down, and they are biologically useless. Oh. Zinc oxide is essentially granite rock, and so it'll stay on your skin for much of, if not all of the day. But the official recommendations are to reapply, and one of the reasons why you will reapply a sunscreen is that we all miss spots. And so if you reapply, the hope and the likelihood is that you won't miss it twice.
Interesting.
And true.
Okay, so once you have the sun damage, let's say...
From sitting outside with baby oil at noon.
But Lori, beautiful.
Which we all did.
And so is Valerie.
But we all did.
We all
right?
did,
I mean,
yes. Yeah, and it's not true that the damage is all done. Many of my patients will throw their arms up and say, there's nothing more that we can do, I might as well go out and cook myself. Not true. It's been well established that your skin cancer risk will be minimized if you do start sun-smart behaviors, if you wear sunscreens, if you wear big hats, if you don't basically get untoward suntans and certainly sunburns. Undoing ultraviolet damage is something that we do day in, day out. And so for overgrown capillaries, we treat those with laser. For brown spots, splotchy pigmentation, that's a combination of skin bleaching creams and or laser, and they work beautifully. Volume replacement is something that is ideal to do because a person after years and years of sunshine will get those deep tissue loss wrinkles. That is entirely from ultraviolet A. And so UVA will go through glass and it will go through clouds, and it causes those deep, deep, deep lines. And volume replacement and resurfacing laser are how those are fixed. We use topical serums a fair bit as well because they work on the epidermis and the underlying superficial dermis. And they, we like serums, and because we love serums. But what the first thing that the eye will see is going to be external part of the skin, and serums work wonders on that. They really do.
Excellent.
Any other questions?
I think that's
Did we
good.
cover everything?
That's excellent, actually.
Well, it's a residency, but
Yeah.
Okay,
That's
but
great.
It's so interesting. Like, it's so interesting. I
agree.
learn new things every day, and yet I've looked into this before, and I still. That's really good. So thank you.
No, thank you. It's my
Thanks
pleasure.
for having you on our blog. This year. I think you're our first actual video and our first guest.
I hope I'm an honorary sister.
That's right.
Now let's go drink some wine.
Exactly.